I wanted to, well, let me start with Ms. Politz. The discussion draft takes the step of prohibiting discrimination in insurance based on a person's health status, things such as disability, illness, or medication history. However, you know, as we're trying to close the door on that with this bill, some are proposing others, and I'm not entirely sure what you said, but I know that you said that, or at least in your written testimony, that insurers should, I'm talking about Ms. Trautwein now, that insurers should continue to be able to alter premiums based on a person's past claims experience. And the way I understand it, that employers would be permitted to change a person's premium, not necessarily on their health status, but on certain activities like wellness programs and those kinds of things. I don't want to put words in your mouth.
Can I explain what I meant? Because that is not what I meant.
Sure, go ahead.
We want health status rating to go away for
Right,
individuals.
but you said that the employers...
We're talking about employer groups where they look at all of their employees, de-identified information.
Right.
And they calculate what their anticipated claims are for the next year. This is done all the time.
Right.
And then they figure out how much they need for reserves and things like that, and they develop a rate based on their particular group. And it's a very, very cost-effective way of doing it. It results in lower rates for the employees, not higher. That's why we were asking for that.
I just want to make sure, and I'm not trying to put words in your mouth, Ms. Trautwein. I'm just trying to understand that, yeah, I want, you know, employers to be able to have wellness programs, certainly, but it's just, it just seems to me we have to ensure the persons who are, you know, unable to achieve a specific physical or other goal are not penalized, and therefore somehow health status comes back again. But I'm not just talking about Ms. Trautwein's testimony. I'm just talking about in general that we're trying to eliminate a lot of these things. Let me just ask you this, Ms. Potts. Can you discuss the role of employer wellness programs and what sorts of protections we can be sure to include to promote the positives without allowing this discrimination, and what it would mean for people if insurers were able to use claims experience and ratings? Sure. Again, I'm not entirely clear on what Ms. Trautwein was saying, so maybe this is not fair, but you hopefully between the two of you, you can answer my question.
I think those are two separate things. So just very quickly on the wellness programs, and you're right, I think there's a lot of interest. I mean, at Georgetown, there are a lot of great programs, sponsored walks, time off, free exercise classes in the building, stuff like that. So I think there's a great deal of creativity and good intentions and good results in a lot of employer-sponsored wellness programs. But there are other programs that even take on the name Incenticare, that all they do is just apply health screenings, make you take certain health tests, and if you flunk them, that's it. Your benefits get cut, your deductible gets raised, or your premium gets hiked by a lot, and there's nothing else. There's no classes, there's no help, there's no nothing. So I think a return to the original notion under the old Clinton administration regs for non-discrimination, establish some standards for bona fide wellness programs, you know, some indication that there actually is wellness promotion, disease prevention activities going on, opportunities to participate, giving employees opportunities to participate that doesn't kind of come out of their hide. Privacy considerations. Employers are not covered entities under HIPAA privacy rules. All that health screen information that goes in, people are very worried about that. And so that's the first thing. And then at whatever rewards there are, I think it's important to just keep that separate from the health plan.
Well, let me,
otherwise it invades.
Do you agree with her, Ms. Trautwein? Or, because if you do, then I don't need to pursue this any longer.
Well, I sort of agree with her. The plan that she talked about, you know, it's not a real wellness program. We're not in favor of those. That's not what we're talking about.
Okay.
We're talking about very unique programs where each person designs their own goals. You know, somebody might be in a wheelchair and the other person might be a marathon runner.
Okay.
That would be silly.
I don't want to prolong it. I think we've.
So I think we agree, but I do think you could have some incentives relative to people meeting the goals that they've established for themselves, though.
Okay. Now let me ask Karen the second question, then I'll quit. Mr. Shadegg, no, he's not here. I hate to mention him with his not being here, but I am. Mr. Shattuck and others have suggested that it would make sense to allow insurers to get licensed in one state and sell those licensed products in others. I've always been worried about that, and I know insurance commissioners don't like it. Can you tell me, under this new national marketplace, what would your thoughts be on a proposal like that? Well, I was going to ask, did I say Karen? Either one of you. I meant Ms. Pauls, but you can answer it too, Ms. Ignani.
Oh, thank you, Mr. Chairman. I didn't mean to step in I thought you were directing.
No, go ahead. I'll hear from both
Actually, just on the last question, I do think there is a combination, as you were suggesting. I do think that it makes a great deal of sense to have a permissible corridor of activities that could be done in the context of wellness, and I think you're right to pursue it. There have been some major advances in the employer context that I think we could take advantage of. Excuse me. If you would like, Ms. Pollitt.
No, go ahead. You can. Why don't you start with Karen, and then with Ms. Pollitt, and then we'll come back to you.
Okay, because
Karen wanted
yes,
Karen.
it is.
I know that
Karen
is confusing me. Go ahead.
I'll be happy to answer after.
All right.
She does.
Sorry, still across state lines, is that where we were? Okay.
Well, it's this idea that you'd allow insurers to get licensed in one state and sell the products in another. I've always thought that was a dangerous thing.
It has been, the experience has been that is a dangerous thing. In association health plans, this is where you see this happening a lot, and it is very dangerous, and it creates opportunities for fraud.
But in addition, now we have this national proposal in the
Right.
draft,
So
so how does
now
that all
you've
fit in with that?
Well, now you've got a national proposal, but in your proposal, a requirement to sell anywhere outside or inside of the exchange, the first requirement that's listed is that you have to be state licensed. So you still need to have a license, you need to work with licensed agents, you need to meet solvency standards. All of those things are established at the state level. You don't need to replace those at the federal level, and you haven't in your bill. So, but I think you need that close accountability. So someone needs to be watching them, watching the health plans all the time. Otherwise, there's great nervousness about selling back and forth. Just the last thing I would mention, and I think it was mentioned in some of the written testimony, I think there may be a little bit of drafting imprecision about sort of what are the federal rules that apply across the board, and then what other sort of state rules or rules under the old HIPAA structure that apply, and that you probably need to straighten out a little bit in the next draft. But you don't want a situation where a health plan can be licensed in one state and operate under one set of rules, but then be able to sell somewhere else under a different set of rules. If your national rules become completely across the board, always the same, you still need to be state licensed, but then this whole notion of selling across state lines, I think, won't matter.
And if you want to comment on
Thank you, Mr. Chairman. I think this is a tremendous opportunity to look very carefully at the regulatory structure and take a major leap forward. Having everyone in allows the complete overhaul that is baked into the proposal now, guarantee issue, no pre-existing conditions, no health status rating. We ought to specify those guidelines at the federal level, have uniformity and consistency, not re-regulate them at the state level, which is causing a great deal of confusion now in the market with different same function regulated at different levels by different entities. We should take this opportunity to make it clear so that consumers can feel protected and know that the health plans will be accountable. We're very comfortable with that. We would have this enforced at the state level. States have done a very good job at maintaining solvency standards, consumer protections, et cetera. We think that's the right balance. We don't believe that, and we have some advice in our testimony about the drafting of the legislation in terms of these regulatory responsibilities. We think it's absolutely clear and key for consumers to understand how they will be protected, where they will be protected, and what the standards are. And we have such duplication and confusion now in the system, it's very, very difficult for consumers to feel protected. So I think this is an opportunity to take a major step forward and really respond to that.
Okay, thank you. Mr. Burgess is next.
Let me just be sure I understand something now. The new public government-run program is going to have to be licensed in all 50 states?
Well, I don't know.
I guess that's a maybe.
It's not clear, I think. It's federal.
This new
I-
public plan, this new government plan,
I would defer to your own staff on that. It is a federal program.
right,
Those are
Medicare is a
not
federal
usually-
program. It's sold across state lines, and it is not, it's not licensed individually in every state.
I don't believe, I don't see the requirement that it has to be licensed by states. It is a federal program.
Right, so it seems to me that if Ms. Ignani's group wants to develop something that meets certain criteria, that it ought to be afforded the same courtesy to be sold in every state.
Well, I don't know that that's a courtesy. I think it's just an administrative factor.
The same administrative faculty then will not call it a courtesy. It just strikes me as we've got two sets of rules here, one for the public sector and one for the private. That seems inherently unfair. This
Well, I
is not
think
what I
those are-
intended to talk about, but I'm not following where is the inherent fairness in the, Ms. Ignani's already talked about carrying a 50-pound weight on her back because she's got to carry the freight that, the cross-subsidization from the federal programs, that the freight they're not paying in the first place. And then on the other hand, are we creating a product that is just, by definition, she can't compete with it because it is something that can be sold without regard to state insurance regulation?
No,
Ms.
I think
Ignani, is
the
that your
rules are-
understanding?
I'm sorry?
Is that your understanding of this new public plan?
I think I know the remedies, I would yield to council, but I understand that the remedies are federal remedies, and I think the entity is chartered at the federal level, but I wouldn't want to be presumptuous in that regard. We've
Ms.
made,
Troutwine, you're the national organization here. Do you have an opinion about this?
oh, yes, sir, we have that's why I said in my testimony that we are very concerned about the fact that a playing field would never be level. And one is the payment, which I spoke about in my oral testimony. The other is the rules. It's regulation at the state level is what we have to meet. Having state premium taxes, state regulations, state remedies.
Okay.
That's not the way the bill reads at present.
Maybe I'll figure out a way to say this more clearly and submit it in writing. Ms. Ignani, I just have to say, maybe I'm a little bit disappointed after the group of 6 met down at the White House, and I know my own professional organization was part of that. And we came out of there with, what was it, $1 trillion, $2 trillion in savings over 10 years? And part of those savings was administrative streamlining,
Yes, sir.
which presumably one claim form instead of
Yes,
50
sir.
or 60, which we have to deal with now.
Right.
I didn't see it reported, but I'm also going to assume that perhaps there's one credential form
Yes.
rather than filling out 50 different credentialing forms every January and taking 2 or 3 full-time equivalents to have them
Exactly.
do that in a 5-doctor practice. Why the hell didn't we do that a long time ago?
Well, sir, that's a fair point. And we have been working now over a 4-year period. As you probably know, we set up a separate entity to actually take on this issue of simplification in the way the banks took on the ATM technology. We have worked with physicians. We've worked with all the specialty societies. We've worked with hospitals, the different types of hospitals, to make sure that we were going to get the language right. We've taken our time doing it to make sure we had that language right in a way that physicians, physician groups, and hospitals felt satisfied that we're actually solving the problem. So now that we did that, we were able to step forward and say, we're not only taking the responsibility of moving forward, we are not going to be doing it voluntarily. We're very committed to legislation. We've said that. We want to make sure it's uniform across our industry. We're comfortable with that, and we will help you draft it.
Let me ask you this, because you've been up here a long time, and you know the rules we live under with the Congressional Budget Office, and a $2 trillion score, whatever it is, over 10 years. The Congressional Budget Office is going to look at that and says, well, if this is something you were supposed to be doing anyway, then we just calculate it into the baseline, and there in fact is no new money to spend. How are you going to deal with that?
This is a very important question you're asking. First, until we made the announcement, no one said from our industry that we were going to be regulated for this, that it would be not only committed to legislation, we would support it and help draft it. So that's a material difference, number one. Number two, for the $2 trillion goal to be achieved, as you know well, it's going to take an interdependence among all the stakeholders to achieve that. There are 4 key areas of savings. That is, if we are going to bend the curve as a nation, we have to take seriously. One is administrative simplification. We need to make sure that not only everything we've committed to, but where we go in the future is the right direction for hospitals and physicians that they can achieve
Now,
the
you
intended.
have no argument from me about
Right.
that. I
Second-
do wonder how we're actually going to get the dollar savings scored by, we all know, when we talked about the Medicare prescription drugs, great, it's much more cost-effective to treat something at the front end
Yes.
than when the target organ is destroyed, and yet the Congressional Budget Office is never going to score that as an actual savings. It actually scores it as an expense because you're going to be treating more people by virtue of the fact that you're treating disease at an earlier point.
Well, we have some ideas on both. Let me just quickly.
Well, we're about out of time. I'm going to submit some other questions in writing. I would just say this. I mean, you see what a fluid situation is, and please forgive me, Mr. Chairman, just close your ears for a minute. Pay no attention to the man behind the curtain. Things are in such flux. Don't be quick to give things up. By all means, work with us, but don't go to the White House waving the white flag as the first volley. In fact, it can be counterproductive. Just my opinion. I'll return it to the chairman.
Sir, if you allow me to answer
Please.
just, Mr. Chairman, just
Sure.
one quick point. I'd be delighted to, you've asked some very important technical questions. I'll be delighted to submit that for the record. But you've asked now, the last point you've made is a more of in the category of right road, wrong road. So let me give you a very direct answer. If you look at the Council of Economic Advisors report, unless we truly bend the cost curve in a sustainable way, not only will we not be able to afford the new advances we want to make in getting everybody covered, we won't be able to afford the current system. We participated in an effort with the hospitals, the physicians, as you know, with the SEIU, with pharma and the device companies, to take our seat at the table to say, as stakeholders, as private sector entities, we could take part of the responsibility of stepping up and saying, we have skills we can bring to the table to get this problem solved. That's what our plans do. That's the point that we're making here. Ms. Capps asked a question earlier to Mr. Castellani about what is the legacy of the private sector. The legacy of the private sector is that we've brought disease management, care coordination. We're now recognizing physicians and hospitals, as you know, recognizing high-quality performance. We've bought the skills to do that. Patient decision support, personal health records, helping physicians not have to sort through loads of paperwork. We're proud of that. We've pioneered those tools. We're implementing it. And similarly, with administrative simplification, we are the key domino to make that happen. We've taken that very seriously, which is why we participated in this effort to try to contribute to this major goal.
Just
That sounds like a good
briefly
leeway.
reclaiming my time. It is
You don't have
not
any
as if
left.
there have not been people willing to work with you on that for the last 7 years
Yes,
that
sir.
I have been here.
Yes, sir.
And I just cannot tell you how distressed I am that there was never this willingness to work. When our side was in power, when a different president was in the White House, I feel personally affronted by this. And it is ironic that you are just at the point now where your industry is going to be delivering on the promise that we all knew it could do. And I don't know what the future holds for you, because there are many people, we've heard it over and over again in this committee this week, that a single-payer system is what is down the road for the United States of America.
All right,
and
let's
all of
get
the things
moving
that you
here.
have done with care coordination, disease management, that may be something you've developed only to find it's never really fully implemented
All right.
and used in the private sector.
All right,
That's a
Dr.
shame.
Burgess.
We could have done a much better job with this. I'll yield back.
I don't want to be tough because I kind of like the dialogue, but we need to move on. Ms. Capps.
I find it interesting, too. But I really want to commend you all for the last panel of the day and think there's ought to be some kind of medal. Did we design medals for the last panel? We should have. This is our 4th day of hearings, too. So if we seem a little kind of flat, you'll understand, I hope. But this is one I wanted to stay for particularly because you're so key, you and what you represent to us getting this right. And that is the goal. And that is exactly where we all are. And Ms. Ignani, I appreciate your taking us down, saying we've got so much we can agree on, and let's at least agree. We don't agree. I don't agree with you on many things, and you know that, but that's okay. We can talk. I want to tell you, Ms. Pellitz, you hold the bar very high, and we're going to try to get as close as we can to the standards you're giving us. And believe me, I have constituents who are reminding me of that every single day when I go home, which is a good thing. This is all across the map. But everybody's attention is now focused on health care, and I salute that. It's about time. Mr. Khan, I'm a suburb. I have suburban counties north of your region, but I'm a big fan, as you know, because now I can boast that each of the 3 counties, I represent part of the 3, now has a county-operated program, and that yesterday we were able to get Mr. Freeman, who speaks very highly of you, to testify as a provider. It's now called CenCal. It used to be Cen, and they were one of the first to get a waiver, and there are some really exciting options that can be brought to the table now. Call them what you want, but they're going to help us deliver care. I have a tough, I want to share what it's like to be a member of Congress and have the phone ring and hear a story, and you know this, but I just want to bring it out and make sure that it's on the record. This panel gives me the chance to relay the story of a constituent whose situation really illustrates why we need to bring honest competition into the insurance market. I represent a little town called Carpinteria, rural part of Santa Barbara County. A young woman is a good member of part of a nonprofit community organization. She has a 12-year-old daughter who was born with spina bifida and needs surgery to replace a stent in her brain. Her mother's income places her mother just over the threshold to qualify. She's not able to qualify for Medicaid. We call it the Healthy Families, the S-CHIP expansion in California. Though her mother's employer does provide coverage, the young girl is covered under the plan, but this plan specifically states that it will not cover the surgery she needs for her life because spina bifida is a pre-existing condition. Ms. Ignani, I'm going to start with you. I'd like to have comment for as much time as I have, and I don't want to go over time. But this plan that this mother has, and in rural parts of my district, there's one option in much of it, one private plan, and there are at most in Santa Barbara County, I think 2, maybe 3 at the moment. So she can't shop around very much. She called my office because she's beside herself. This denial is for a condition that this young woman was born with, and this surgery is needed to relieve the pressure of fluid on her brain. People have been talking about pre-existing conditions in the private sector for a very long time. This is real time. This is happening today in my constituency.
And Ms. Capps, I think there is no legitimate answer to your question, but to say this is why we have worked so hard to propose change, and the comprehensive proposal
But it hasn't happened yet.
It has not happened yet because we have a system now where people purchase insurance if they're doing it individually when they feel they need it.
This is part of her employment. But
if it's part of an employer, then guarantee issue is
small
the rule.
employer, a nonprofit organization with a very minimal amount that they can spend for employee-covered care. But let me see what some other comment is. Maybe Mr. Khan, what would if this young mom was working for this nonprofit, which abounds in Los Angeles as well, what option might she have?
Well, Congresswoman, and by the way, you have a beautiful area that you cover. Your district's beautiful. And you did have the first of all of the county organized health systems there. The problem is a structural one, which is that the way our regulations and our markets are set up right now, that an individual, or if they're in a very small group perhaps, because usually pre-existing conditions are not excluded from group coverage. It may be such a small group, however, that it is. That could be the
Less
issue.
than 10
so
employees.
not knowing the situation,
Sure.
that could be the case. And there's, under the current system, to be perfectly honest with you, there's no good answer for that situation for the individual or in a small group like that. That's the problem with the system right now, and why I think we all agree we have to change the system. Now, depending on her income level, it's
Not
possible.
very high.
Not very high. They could actually become eligible for Medicaid if they spend down enough, depending on what her income level is.
Pretty big price to pay.
And it's a very big price to pay. But that's the problem, is that we have a broken system right now that needs to be fixed. And that's why we're all here, because of those kinds of situations, covered but not covered, which is
Do you
shameful.
see our reform legislation being a remedy?
Yeah, absolutely. I think that the solutions that are being addressed.
From both the private sector and this public option, of course.
Well, I think that what we're talking about is reform of the rules around coverage. And indeed, you would accomplish that. Because once everyone's covered, then the pre-existing conditions issue should really go away. The problem right now is that, and we don't do individual coverage, we serve only low-income people, of course. But the problem with the system right now is that where people are not covered, they decide once they get sick, they need coverage, and that's why there's underwriting. I'm not defending it. It's just there are no bad guys in this play. Unfortunately, it's bad structures. It's a bad system.
Right, which is why it calls for intervention from us. Would you? I mean, I'm not looking for support for that, but I applaud. This is finally the moment that all the stars are aligned. I think we would all agree that we're going to, not everybody's going to be maybe pleased with the outcome, but we are going to make progress. And I'm just so hopeful that we can do it in a very bipartisan way.
And Ms. Capps, I would be happy if you think it appropriate to help with your office and see if we can look into the case and see if there's anything that can be done. I would be delighted, as a mother, I would be delighted to do that.
Thank you. Mr. Whitfield.
Thank you, Mr. Chairman, and thank you all for your testimony. One of the common reasons given for having a public option is the fact that there's not competition, and particularly in rural areas. And there's probably an obvious reason for this that I don't understand, but in the prescription drug benefit under Part D of Medicare, in my rural district of Kentucky, there were like 42 different plans offered to Medicare beneficiaries. So why are there so many plans offered under the prescription drug benefit, but not plans competing with each other in the other sector? Would someone answer that for me?
Well, prescriptions are a little different just because you don't need the provider network. I mean, if there are pharmacies nearby or even mail order pharmacy, it's easier to insure the costs of prescriptions.
So it's just the fact that there's a lack of a provider network, and putting that together is so difficult.
I would expect, I'm not familiar with your district, but prescriptions are a more kind of national market than other healthcare.
Okay.
I think, Mr. Whitfield, one of the things that we have observed is that often there are products available, but particularly in rural areas, if individuals don't have a broker, for example, they haven't been presented with the information, they don't know where to go, which is why one of the first things that we've suggested is this concept of having an organized display on a site, it could be a state site, of the health plans that are available in every part of every state.
Right. Okay.
And organized it so people can understand what's available. That would be, I think, a major step forward.
Mr. Kine, would you want to say something?
Thank you, Congressman. I would just add that the challenge in rural communities, beyond the pharmacy situation, is that if you're the one hospital in town, you probably don't have to negotiate.
Yeah, right.
So it's not very attractive for a health plan, and that's why you don't have competition. Now, I will say, though, that in California, we have a number of our public plans that compete with private plans, and some of those are in rural areas as well, Kern County, for example. And so there is competition, but again, it's by the nature of that market, because all health care is local still, and it probably will be for the most part under the reform. And so it depends on that market.
Now, Ms. Ignani and Ms. Troutwine, you all are both involved in associations that represent companies that I'm sure provide a lot of group insurance plans to rather large employers. Are you at all concerned that employers, because of this public option being available, might just say, you know, to save money, we're just not going to provide health insurance anymore?
We're concerned about that, sir, and we're also concerned about employers seeing the differences in the numbers, as I indicated in my oral testimony, that there would be very little available or left in the private sector. because the incentives are so compelling. And I think that there is a strong value in having the best of both, doing a better job in the safety net and then doing a better job, as we've talked about, improving the rules.
Well, does this draft bill provide the protection that's necessary to protect the private sector?
Well, I think that it's not, we were very concerned, as we indicated, that we would not see a private sector sustained because the playing field isn't level. If you pay at Medicare rates, it's such a major differential that there's no way to sustain a private sector.
Okay.
But Congressman, just to add, under the bill, if an employer buys through the exchange, they have to agree to let their employees pick the plan. And if they elect not to offer coverage and to pay the fee, then the employees still get to pick the plan. So there's no way that employers can opt to put people in any of the plans available in the exchange. It's always up to the individuals.
Are you saying that employers cannot just decide to refuse to offer a plan?
Employers first make an election. Are they going to play or pay? Are they going to offer
Right.
a plan, or are they going to pay?
Right.
And if they're outside of the exchange, they could offer a plan, and they would only have the choice of buying private plans. And then if they come into the exchange, it becomes kind of a defined contribution, but the employees get to pick the plans that are offered between public and private.
Ms. Troutwine?
Yeah, I just wanted to add to that there is language in the bill that after a period of time, even employees that are a part of a program where there is an employer-sponsored plan can elect to spin off of that plan to go into the exchange. This is a direct threat to employer-sponsored coverage. We're very concerned about this because you have to maintain a decent participation level inside an employer group to have that balance of risk that I was talking about earlier. So I think that is something that we should really look at, whether that's a good idea to keep that in the bill language.
Yeah. I guess my time's expired. Well, can I just ask one other question? I know you've been here for hours, but just one other question. Ms. Troutwine, in your testimony, you talked about it's critical that there be a financial backstop to accompany reforms of the individual and group insurance markets. And I was curious, now what do you mean precisely by backstop?
Well, it could take many different forms. It's kind of what I talked about earlier, this idea of reinsurance. You know, some states today use a high-risk pool to backstop their individual market, but it doesn't have to be that. It's just something to make sure that we address the cost of high-risk individuals. This is a particular problem during the first 5 years, I'm guesstimating that amount, because it's going to take us a while to get the hang of this individual mandate and enforcing it. We won't have everybody in overnight, and so there will still be initially adverse selection, the same that we have today in this market, and we've got to do something to make sure that those high-cost cases don't make the cost of coverage go up for everybody else. So we're not trying to wreck the proposal. We're saying you need to add this thing in here to stabilize your proposal so you will not have these unintended consequences.
Thank you, Mr. Chairman.
Thank you. And I know different members mentioned that they're going to submit written questions, and we asked them to get them to you within the next 10 days or so and get back to us as soon as you can.
Mr. Chairman, I was also supposed to ask unanimous consent that the Blue Cross Blue Shield data be made part of the record.
Yeah, let me see it. I have something too here. I'm glad you mentioned it. I almost forgot. So you have, what is this, Blue Cross Blue Shield you called it?
Yes, Ms. Fox testified, as part of her testimony.
I'm told that it already has been, but if it hasn't, then we'll do it. And I also have to submit for the record this study by Healthcare for America Now showing that 947 of the 94% of the country has a highly concentrated insurance market. This is from the American Medical Association. So without objection, we'll enter both of these in the record. Thank you very much. I thought this was very worthwhile. It's a complex issue, but we appreciate your input and your optimism as well. Very important. So thank you very much. And the 3-day marathon of the subcommittee is now adjourned. Without objection, is adjourned.